We are going to get started right at noon. Welcome, welcome. Hello, everybody. Is it too late to blur my background?
Never too late. Time is always on our side.
All right, it's noon, so I'm going to go ahead and get started. My name is Danielle. I'm the executive director of NAMI Northern Illinois, which is an affiliate of the National Alliance on Mental Illness. I just wanted to say thank you all for coming and joining us. I hope you have your lunch. Please eat it as you're able. We have Sadie Cobio here with us today to talk about co-occurring disorders. I just want to mention a few things before we get started. So it is our 40th anniversary this year, so we've got a lot going on. And one of those things is a Mental Health Month event. We are bringing Brandon Novak here. You might know him from Viva La Bam or the Jackass movies, and he's coming to talk about his co-occurring illness with his mental health and his addiction. So I think it'll be a very empowering event, and it's May 16th at Embassy Suites. We've also got a lot of other things coming up, and I'm definitely happy to share our website with you after this. But onwards to our presentation. Um, so meet Sadie Cobio, a licensed clinical professional counselor and behavioral health leader who believes in the transformative power of behavioral health advocacy. Sadie is currently the assistant administrator of community behavioral health services at Rosecrance, where she's instrumental in the strategic development and enhancement of the services to continue to meet the evolving needs of the community. With over 10 years of experience spanning therapy, program administration, and academia, Sadie's mission is to foster environments where individuals can confront challenges, learn, and grow. When Sadie isn't shaping the future of behavioral health, she's an avid fan of Georgia Bulldogs football and has a soft spot for new adventures and exploring new cuisine. A person of unwavering optimism, Sadie firmly believes that growth, while sometimes painful, signals progress, and she looks forward to helping others navigate their journey. Sadie, thank you again. Just some housekeeping. You won't be able to speak, audience members, but you can use the chat feature, or the Q&A. If you have questions, just as they arise, you can put them in there and I will read them to Sadie. And then also at the end, I will follow up with a evaluation form. If you're looking for CEUs, you can just pop that back over to me. Thanks, Sadie.
Thank you so much for having me. I am going to share my screen. Give me just a second. All right, hopefully at this point you guys are seeing kind of that first slide that says co-occurring disorders from stigma to support. As Danielle shared, as you guys have questions, please pop those in the chat. She'll stop and kind of share those pieces so we can answer the questions as we go. And if you have questions you want to hold till the end, that's totally fine. We'll save some space there. So thank you so much for the introduction. I'm excited to talk a little bit about co-occurring, give some education, and then how do we give some treatment and support as a whole. So here's what I'm hoping that you walk away with. By the end of this training, you'll be able to know a little bit more about co-occurring disorders, the epidemiology, risk factors, assessing and diagnosing, and then some treatment and clinical considerations. So what is a co-occurring disorder? It's basically the coexistence of a mental illness and substance use disorder. Another common term that you'll likely hear is dual diagnosing. They're used a little bit interchangeably depending on which literature you're looking into, but ultimately the same thing. We're going to talk a lot about that and its treatment. Before we get started, you can take out a piece of paper, just kind of take a moment to reflect, get some baseline of where we at. So think through some of these questions. What develops first, the mental illness or the substance use disorder? How can a clinician tell which is the primary concern when they're working with them? And if a person struggles with mental health and substance use, which should be treated first and why? I want you to take like 60 seconds to just think through or jot down if you're taking some notes. Um, what are your kind of automatic answers to this piece? You may still be jotting something down or thinking through all those questions. That's okay. We're going to keep moving forward. Through this presentation, you'll learn a little bit about how to guide and understand each of those pieces. So let's talk prevalence. Substance use disorders and mental health disorders, as you guys may have some knowledge, is um, really prevalent where we are. In 2018, there were 20 million individuals in the US over the age of 12 that were diagnosed with some sort of substance use disorder. Alcohol, marijuana, opioid is listed there for you, but there's lots of other substances that we know as common, with one of the ones kind of on the rise is xylazine, which is actually used for animals and not for human consumption. We've had some humans consuming that, and so that is a substance use disorder that we are looking at a little bit differently. There's lots of different facilities that provide specialized substance use treatment. At Rosecrance, as Danielle shared that I'm a part of, we have outpatient and residential locations in the Rockford, Champaign, McHenry, and Chicagoland areas, as well as Madison and then Jackson centers in Iowa that provide, outpatient level of care if they want to come in, attend groups, have multiple hours of treatment, or be in a facility, for 20 to 40 days where they're getting kind of comprehensive treatment. And we'll talk more treatment in a minute. On the mental health side, there's 42 million folks who are living with a mental health disorder. And so mental health is, what we think about is bipolar disorder, depression, anxiety, lots of different disorders that kind of bridge together with substance use, which ultimately brings us to co-occurring. Something I think is really interesting is that 15% of all lifetime mental illnesses begin by age 14, which is young for folks, right? By the age of 14, they've usually had some sort of prodromal symptom or some awareness that things may be looking different. And 75% of all lifetime mental illness begins by the age of 24. In 2019, there were 8 million Americans who were diagnosed with mental health and substance use disorders. And among all of these individuals, they had at least one substance use disorder. That is a huge amount of folks who are diagnosed with some sort of diagnoses, mental health and substance use. One of the things that I think is worth acknowledging as you're in treatment with individuals is that women are at a higher risk for developing a co-occurring disorder. It's estimated that 4.3 million women were diagnosed with both a substance use and mental health disorder in 2018. And we've often seen some of those numbers climb and then dip a little bit through some of the changes that we have in our environment. Okay, so we have under our belt all of the things for prevalence. So let's talk some risk factors. When we think about risk is really important to evaluate for individuals when you're working with them for lots of different reasons. It can help you really get a better understanding of who they are and how to support them. So we'll walk through a couple of key risk areas that we know. Biology is one piece. Some individuals are just wired that they're a little bit more attracted to drug and alcohol use. This can come from an array of different things. It may have been through prenatal development, some sort of, early childhood exposure, an accident, an injury. But ultimately, it changes that chemical makeup and function of our brain, making them a little bit more wired to be attracted to those pieces. The second piece is genetics. Having a close relative, somebody you're related to having a substance use or mental illness may increase the likelihood of development for one or both of those diagnoses. The third one we have is trauma. We hear this, we hear about trauma a lot, trauma-informed care in the work that we do. Trauma would be any sort of exposure to trauma or near-death experiences. And I think one of the things to note as a risk is it's not necessarily you as the assessor or the counselor indicating this as a trauma, but the individual you're working with has identified this experience as traumatic or stressful to them. Having these traumatic experiences, individuals may seek out drugs or alcohol then as a coping mechanism, followed by some sort of mental health related concern like depression or anxiety or PTSD. The fourth risk we have on our list is environment. Growing up in a specific environment that's permissive to heavy alcohol or drug use gives you a little bit more risk. You're in a space where it's normalized and consistently leveraged. You start to learn as the person in the home that this is the way that we cope or we navigate. And so it's an important piece to kind of evaluate how did they grow up in their environment that helps them kind of understand how they move forward if they're experiencing something difficult or stressful. Life experience. Sometimes our life experiences lead us to utilizing some sort of substance. And so folks with chronic illness or chronic pain may seek out some of those experiences, again, as a coping skill or a way to navigate or mitigate some of their pain, which ultimately can contribute to some of the mental health symptoms. And then the last risk we have on our list that we've at least identified here is using drugs during childhood or adolescence before your brain's fully developed. Listen, we know that kids' brains are not developed. And I say kid, but really this is up to 20, 25, 26, 27 years old. The brain is still in its prime to be developed and grown. And so when substances are used, it ultimately influences the brain on how do we make decisions. Our prefrontal cortex or our executive decision making is made, isn't fully developed. And so some of the decisions that individuals make may not be the best. We talked here about, 6 key risk factors. And I want to make note that there are lots of other risk factors you may think about when you're assessing somebody. So keep in mind, these are just 6 to look at, to note as you're assessing, which we're going to talk about in a second. But there's lots of other risk factors that may take place. Okay. So assessing and diagnosing. One of the things I like to share about assessing and diagnosing is really understanding the primary goal of assessing. One of the biggest things that I encourage clinicians to dive into and look at when you sit down with a human across from you or across the screen is really trying to understand the behaviors and the symptoms that you see. By starting from that lens and not trying to fit them in a diagnosis or seek out, what issue or other concern are they having, it really helps you take in the whole story and come back with a comprehensive assessment of what's going on with that person. So the primary goal of assessing is some sort of detection for mental illness or problematic substance use. Listen, I want to normalize the fact that we're going to have anxiety, we're going to feel sad. There are individuals who may consume alcohol, right? Those things take place. What we want to see is it really debilitating for them? Are they utilizing, substances so much it prevents them from doing their job or interacting with their family? And so it's utilizing and asking some of those questions that help you get to understand that individual's story. Another primary goal of this is, are they meeting criteria for the DSM-5 TR diagnoses? In the day and age that we live in, typically with an assessment comes a diagnosis that insurance will cover that service, right? And so when you're asking all of these questions to people, I would challenge you to ask all of the questions that get you to an appropriate diagnosis. And note that it's going to be ongoing, right? Symptoms may increase or decrease over the time of treatment. The goal ultimately is that symptoms decrease, problematic use of substances decrease, and ultimately, we discharge them out into the world independently. But we know that through treatment, things ebb and flow, life experiences happen. And so just note that even upon this first initial assessment, the assessment's going to be ongoing for folks, and you may have to pivot your treatment to match what that individual may need. I talked a few slides ago about some common mental health diagnoses, but I wrote some here that you may see in conjunction with substance use. Now, keep in mind there, depending on the region you're in, you may see certain substances a little bit more commonly than others, and a flare-up of some when things become a little bit more common, for lack of better terms. So here we have listed some common mental health disorders: major depressive disorder, bipolar and related disorders, which would be your bipolar 1, bipolar 2, anxiety disorders, which would include, generalized anxiety, agoraphobia, any sort of like social anxiety, schizophrenia or the schizophrenia spectrum disorders, personality disorders. I think the most common we may see, serving individuals we do out of Rosecrance is like borderline personality disorder, as well as PTSD. I think PTSD is the most known one, but I just want to acknowledge like acute stress disorder, which is just a shortened period of time, but still heightened symptoms, can also be one that we see if you may see an individual shortly after a traumatic experience. So those are our primary goals, common diagnoses that we see. So how do we assess the human? Well, lots of different ways to assess, lots of different questions to utilize, but by using a biopsychosocial approach, you're able to capture key areas to understand where that person's coming from. You can see in the table in that middle column, we talk about, how do you ask some questions or look for some areas for substance use? And then on the right of that table, there's a piece that talks about mental health areas of concern. When you assess from this approach, you're looking at the biological components, the psychological components, and the social components. Each of those areas feed what we see in the DSM-5 TR to help you understand what's going on with somebody. So from a biological sense, if you're assessing this person, you're trying to understand what's going on, trying to figure out what level of care they need, whether it's inpatient, outpatient, residential, what are some things that you can look at? From a substance use end, you can look at, did you do a UDS or a urine drug screen to understand, do they have any active substances in their system? Are they going through symptoms of withdrawal? Are there any medical signs of toxicity or some sort of impaired cognition? Sometimes the first thing we notice is something that alludes to them being on some sort of substance, right? And so you may acknowledge like, hey, maybe we need to get a urine drug screen, understand what's going on with this person before we move forward with an assessment. On the mental health side, the biological components that you may see are some sort of abnormal labs, a neurological exam, or the use of psychiatric or other medication. And so there's some sort of altering in their system of neurotransmitters or others to get them to a baseline space. The second piece that we want to look at is psychological. When you're looking from the substance use end, are they showing some sort of intoxicated behavior? As I was alluding to in biological, if somebody approaches you and maybe they're slurring their words, maybe talking at a different speed, you may start to pick up on some pieces that's telling you something else is going on beyond just, potentially their baseline. Do they have a history of trauma? We spoke a minute ago that PTSD and acute stress disorder can be common diagnoses that are given in co-occurring individuals. And we're going to talk in just a second about adverse childhood effects and how that can influence individuals' risk there. But ensuring that you're doing a full evaluation of the trauma history and asking the questions from the individual or the client's lens to understand how that may be influencing them. You can also leverage and utilize substance use assessments. There's lots of assessments out there that can walk you through, if the individual's identified alcohol is my substance of choice, walking them through an assessment that helps you understand how frequently are they using, at what rate are they using when they do use, have there been times where there's a period of a break or other, as well as any documents that substance misuse has occurred in the past. We know as providers, we have to be able to see some other records if they've been in our care before, other care before, if they're being referred by somebody. That collaboration can help us inform that person and ultimately support getting them to their appropriate treatment. Mental health, on the other hand, you can do some mental status exams. You can use the same sort of assessment style. There's, the PHQ-9, the GAD-7, lots of different assessments that you can utilize. Also taking into account their stress or situational factors, the environment that they're in. Are they homeless? Are they between jobs? Are there other pieces that are going on for them? Self-image and personality, and just how they view themselves, how they understand or see themselves, is important to understand how to support them. And then lastly on there, again, measuring that trauma history. The last piece we look at is social, and these will kind of mirror each other on both ends. But is there a family history of substance use or mental illness? Vital question to ask, understand where they're coming from. Who do they hang out with? How do they spend their time? Who are their social supports? Do they have a military background? What is their education or housing status? Do they have a legal history? And I think a key part for social is understanding the cultural background and potential norms in different cultures. So we've taken in a biopsychosocial approach, and now one other piece that we want to look at is adverse childhood effects. ACEs is what it's also known as, which I think is why I have such a difficult time saying all three words. ACEs is something we want to evaluate. You've probably heard about this. It's been a hot topic for several years, but it's a really informative way to help us understand folks. So it's looking at potentially traumatic events that occurred between 0 and 17. And so this could be experiencing violence, abuse, neglect. It could be witnessing violence in the home or the community, having a family member who has died by suicide or had to be hospitalized or other due to an attempt to suicide. And these ACEs are linked to a plethora of things: chronic health issues, mental illness, substance misuse into adulthood, and ultimately can negatively impact education or job opportunities if not kind of caught and treated early on. I put on here the ACEs questionnaire just so you could kind of see what that might look like, what those questions might look like. But the important thing to know is assess fully. It's important that we understand their experience from their lens, which will ultimately inform the care. Um, and note that just because there's a higher score doesn't automatically mean that there's mental health related issues. People can have higher scores and have a greater risk, but not necessarily come to having a mental health or substance use diagnosis, or both together from a co-occurring lens. What's the impact of ACEs? How does this influence us as providers, as an organization, as a community? Preventing ACEs could potentially reduce many health conditions. We have 1.9 million cases of heart disease and 21 million cases of depression, which a lot of research suggests if we were able to prevent some of these pieces, folks wouldn't have as many health-related issues as they do. Children are at a greater risk. Some children are at a greater risk than others. Depending on what cultural background or group that you're a part of, the amount of ACEs you've experienced in your lifetime as a young child or as a teenager can really influence how things kind of go as they get older. I think the other thing worth noting, and I think this is an impactful statement, but ACEs are costly. When we have individuals who experience traumatic events, go on to do lots of different ways of coping that feel best for them in the moment, it really influences the families, the communities, the society, and ultimately how individuals like us get into wanting to care and provide services to individuals to support them on that journey of recovery, whatever that may look like for them. There's some consequences to the ACEs as well. And I'll spend more time on the toxic stress piece, but I think it's worth acknowledging that by having ACEs, it can lead to some longer negative effects on health and well-being, as we were just talking about. Individuals are at an increased risk for STIs or STDs, maternal or child health problems, teen pregnancy, sex trafficking, and even some chronic diseases, as we were talking about before. There's lots of different things that can feed you having a high or low ACE score, which can ultimately put you at greater risk for the future. But one of the things I think worth noting, and this is this last bullet point, is that Many of these pieces, ACEs and other associated conditions, like living in an under-resourced or racially segregated neighborhood, frequently moving, experiencing food insecurity, can lead to what we call toxic stress. And toxic stress from ACEs can ultimately change brain development. I think one of the things you've probably heard by now is everything we do influences our brain in some way, shape, or form. We may not see it in the moment. We will see it as we get older, but it can influence our ability to attend to something, paying attention, remaining focused. It can influence our decision making when we're in significantly stressful environments, or that's kind of how we grew up. It influences our ability to learn, and ultimately respond to stress in a way that can be productive. Children growing up with toxic stress may have difficulty forming, healthy relationships and stable relationships, as it may not have been modeled to them. I think we all experience our own life experiences that kind of form us to be the human we are today and will go on to be. But when we have greater levels of stress, it really influences how we view the world, how we interact, and ultimately how we cope. Some individuals may also go on to have unstable work histories as adults and struggle with finances or jobs or depression. And I think the key piece of this is that if we can't support them as they're navigating this piece, this goes on to affect their own children if they were to have any. Earlier, I was talking about, all of our life experiences, the things that we go to for comfort, for support. That's what we learned as we were young. Individuals who then go on to have children, that's ultimately how their children learn. And so part of it is understanding the cycle, breaking the cycle, and helping support them from a different lens with the knowledge that you have. So here's some do's and don'ts. I think this is always kind of helpful as you think about assessing and understanding an individual, and do they have a co-occurring or dual diagnosis? So keep in mind that the assessment is about getting to know the person. Listen, humans are complex beings. They have lots of their own nuances. We are all unique in our own way. Keep that in mind. Listen and hear from their lens. Tools alone cannot provide that whole comprehensive assessment. It's going to be the questions that you ask and helping to understand how it informs their story so you can support them best. Do always make every effort to contact all involved parties. Collaboration is key. I know it's a challenge. I know it can be hard to get a hold of individuals. I know that it can be, each of us are seeing from our own lens. The more individuals we have to understand and inform this human story, the better we are at being able to provide service to them. Don't allow preconceptions about addiction interfere with learning about the client's true needs. I think this piece is very, very important to know for yourself as a provider. Do you have your own kind of preconceived notions about addiction, and how may that ultimately influence your view or understanding of a client when they come in? So something to have some self-awareness on, and support for yourself. And then do become familiar with diagnostic criteria. I apologize, I didn't put the new DSM in there. We are in the DSM-5 TR. That one's on me, so note that is the older version. But become familiar with diagnostic criteria. As a clinical staff, is that you always have that at your disposal. Please don't feel like you have to memorize and know all of the things. Use that, open that up, look at the things, ask the questions. I think the better we are at understanding those pieces, the more support we can give to our clients. Don't assume there's one correct treatment approach or program for any sort of co-occurring disorder. The purpose of the assessment is to collect all of that information, understand where they are in their stage of change, and matching individualized what they need for their care. Don't be afraid to admit when you don't know something, either to your client or yourself. I always tell individuals, the seat I sit in, I get to supervise leaders and have some clinical influence at Rosecrance. I tell people, you don't know what you don't know. And if you don't know and you can't say it, there's no way for somebody to help. So feel comfortable saying like, hey, I'm not sure. I'm going to have to get back to you on that one. I think ultimately as humans, we feel like when people acknowledge that, they're being authentic with us and that we can continue to help them move forward in their journey of recovery. And if you don't know, ask. Find a clinical supervisor, a peer if you're a licensed human. Find somebody who can help you get to the answer and be informed, or point you to a training or other that can help you be prepared for the next time you stumble upon this situation. And then do remember that empathy and hope are the most valuable components of your work with a client. When you show up with unconditional positive regard, empathetic, and willing to hold the hope balloon for them as they're navigating those pieces, that ultimately is key to their success. Clients, in literature, we talk about how clients' success in treatment usually stems from their relationship or rapport that they have with their clinician, which is key. Okay, so we've talked about assessing, we've talked about risk, we've taken in all of these pieces. Let's talk about treatment and clinical considerations. There's a couple of models that I like to talk about when we talk about co-occurring, and I think it's just a way of understanding the individual. First one we talk about is self-medication model. Having a mental illness makes somebody more likely to develop a substance use. This is the most evidence, there's the most evidence for this model, which ultimately means like their mental illness will increase their likelihood of using some sort of substance to navigate what they're handling. Most commonly, we see like marijuana use or alcohol use, or pill or crack or cocaine use to kind of offset what they're feeling. Shared liability and mutual maintenance model. There are shared reinforcing relationships between traumatic stress and mental illness that underlie both of the disorders that that individual is presenting with. We also talk about the susceptibility model, meaning early stress exposure leads to mental illness, making people more vulnerable to develop a substance use disorder later. Ultimately, the stress we have early on influences us and how we navigate life, getting to a mental health disorder, and then seeking out substance. And then the last one we look at is a high risk model. Substance use increases the risk of trauma exposure by placing individuals in high risk situations or impairing their detection to the cues in their environment. And so this would be things like drug related crime. They're putting themselves or kind of seeking out kind of those situations where there is more concern or risk. So there's three ways of approaching treatment as a provider: sequential, parallel, and integrated. Integrated is our most preferred model, and so I'm going to spend the most time talking about that. But let's start with sequential. We treat one disorder at a time. As you may guess, this is our historical approach. It often can lead to worse outcomes, as one disorder may worsen and not be treated at all while you're primarily focused on the other. Parallel, we treat both disorders, mental health and substance use disorders, by separate providers in separate systems. It typically doesn't lead to collaborative comprehensive care. We know that when we can be collaborative and supportive to individuals, they ultimately get the things that they need. One of the things that makes this challenging is when you have separate providers and separate systems, sometimes that communication can be difficult. And so parallel isn't usually our highest encouraged. What is integrated, which means you are addressing all diagnoses, all symptoms through one team, actively combining any sort of intervention for mental health and substance use, ultimately treating the whole person. This gives you the ability to have ongoing assessing, and this individual is getting some holistic approach to their care. Some of the key features of an integrated approach, which again is our preferred method, is shared decision-making. The client is then actively involved in decision-making. What I tell people is, you know, if I was a workout trainer and I came to you because you wanted to work out and eat better, have a healthier lifestyle, and I told you you're going to do P90X or you're going to run every morning, you may not want to be as involved with me as your personal trainer, right? You had no say in this. The cool thing about an integrated treatment approach is the client gets to say, hey, this is what I'm ready to work on. Here's where I'm at. This is the stage of change I'm in. And so they're bought in to move through their recovery because they have an active part in their treatment process. The integration of services, it's one treatment plan, one set of goals, one relapse plan. So everybody's on the same page, speaking the same language. We know there's a million different ways to say things. And so by having it all in one place, The client's getting a consistent message through their journey of recovery. The other piece is it's comprehensive. So if client comes up and has different needs like housing or case management, needs to get support finding a job or maybe some education, social skills training, it's all in one place. You as a team can then make the recommendation on how to move forward for the client as they are moving through their journey of recovery. The other couple of pieces is there's some assertive community outreach, which means you can use different engagement strategies to connect clients with what they need. And you have lots of people who can inform from that lens. There's a reduction of negative consequences. You have the ability to take small incremental steps to reduce the harmful consequences of their use. And then you're not just attending to the negative consequences of the substance that they may be struggling with. And it's a long-term perspective. Some clients manage illnesses really quickly, others have years to recover. And so you can kind of accept people where they're at in whatever path or journey that they're on, understanding that ultimately recovery is a lifelong journey. It's not something that you work on for a week or a day or a year. It can look different for each person, which is ultimately why this individualized portion is vital. A couple of other key features of the integrated treatment approach is its motivation-based treatment. I talked earlier about the stage of change or stage of motivation that that individual may be in for recovery. Where they are is where you get to match. If they're active and ready and motivated and want to make a change, you're going to approach that differently than if they're just kind of questioning, knowing it may be an issue or somebody else is telling them it's an issue. Each person gets to support them from that lens. And then the other piece is you get multiple psychotherapeutic interventions. That means this client has, it's recognizing that this client has their own set of beliefs and preferences and values that ultimately influence their goal, as I was sharing. And so you can tailor and utilize different interventions to support this client on their journey of recovery, as they manage kind of the success of where they are and ultimately getting to what I like to say, that successful discharge space that says, I did it, I've navigated all of the things, and now I get to live my life how I am, knowing that they can come back at any point if some sort of stressful event or change or other occurs. But this really gives you the opportunity to individualize each of those pieces for them. Here's some of the skill set things that people can or should or may need to develop. Just another lens to look through. When you think about co-occurring disorders, you think about symptoms and things that kind of pop up. These skill sets are what would help the person move through recovery. So through some emotional regulation skills, we talk about CBT, DBT, problem solving, conflict resolution. How do we really learn to navigate and manage our emotions in a productive and helpful way? I like to say that emotions are temporary. They don't have to stay with us forever. Sometimes they feel all-consuming when they're occurring, but they're temporary. How do you help your client understand the emotions temporary and build the skills to navigate when those emotions feel really big? Communication skills. We know that communication can break down in like 25 different spaces. How do you support them in communicating clearly, understanding social cues, and maybe when they need to remove themselves or set a boundary for themselves, which we'll talk about in a second. Or teaching them how to appreciate another person's point of view, but they don't have to agree with it, just acknowledging that it's there. The better social skills and understanding they have of their communication and perception of their communication can ultimately help them in their recovery. Some of these executive skills, organizing, planning, scheduling, how do they put into their life the skills that will help them be substance use free and making good decisions and healthy coping skill choices. I don't know about you guys, but sometimes we have to slow down and say, like, we got to put it on the calendar. I got to find some time. If I know something may be a particularly stressful time, I will back that up with something that's not so stressful. So I feel prepared and ready to navigate that next situation. It's the same with our clients. How do we help them see that you don't have to do every stressful thing back to back to back, and then you're setting yourself up for failure? Let's find those things that also fill your cup in a positive way. Lifestyle changes are huge. I know sometimes people don't like the term lifestyle. What I like to say is ultimately it's how you want to choose to live your life. And there are some things that have to change in order for you to get better. Sleep is huge. If we're not sleeping, we're probably not great the next day. And because we're not great the next day, we're probably not sleeping great. It's kind of like this really sick cycle. So how do you stop that and help them create healthy sleeping habits, have good sleep hygiene, setting themselves up for success? Getting them to a primary care provider to address any medical issues they have, or supporting them in navigating a good relationship with food. Depending on how they grew up, they may not have a great relationship with food. And so getting them connected to understanding nutritional choices, healthy eating, because food is fuel, and how we fuel our body can influence ultimately how we interact as well. We talked a little bit about communication, but family relationships or support relationships are vital in that recovery, that they have positive, healthy individuals that understand their journey and are also on that journey with them. Addressing any job skills or work related issues. We know work can be stressful. And so when individuals automatic response is, I'm stressed, I want to do this, or I'm struggling with work and I had this difficult conversation, this is how I want to respond. It's helping them acknowledge those pieces and navigate forward in a little bit of a different way. As well as managing legal issues. Legal issues can be stressful. It's bigger than us. I was joking with Danielle before we started this, like sometimes legal language feels like it is a whole other language. And so how do you support the client on navigating that system and leveraging resources that you may have at your disposal to help them understand moving away from that legal system and reducing any sort of recidivism? And then knowing that recovery is a process. There's no one linear way to get there. It's about learning some skills, understanding your triggers, building those skills and support so that you have positive, healthy individuals to rely on. We like to talk a lot about replacement activities in our IOP and outpatient care groups, that it's not just about doing other things or avoiding or putting all these really good things into place, right? It's about knowing the trigger, finding what thing can you put in that place? How do you go on some sober living events and connect yourself with individuals who are also on their journey of recovery and committed to that change? And the last piece I will say, and then I will take some questions from you guys, is acknowledging some things as you're working with folks. Working with children who, working with clinicians who have specialized training in substance use and mental health. It's vital that when you're seeking support or you're giving this support or other, that you are working with somebody who understands that lens and how to best support you. As a provider, be intentional in being a part of those interdisciplinary staffing. So that's staffing with the clinician or the case manager or the provider, or maybe it's the legal system, DCFS, APS, whatever system is involved for that human, whoever is sitting at the table for that human's life, making sure that that has an open line of communication for those individuals. Knowing that there's different ways of providing the support. So individual counseling is great, but there's also peer support groups or general support groups, or aftercare recovery resources. How do you help them get connected while in treatment with you so that when you go away from their table, they have lots of other people still sitting there to support them? Ensure that they have access to some sort of pharmacological therapy. If they have depression or anxiety or schizophrenia, they may benefit from a medication to kind of equal them out. I refer to it as, think about the image of having marbles sitting in your hands. Sometimes people's levels are a little bit lower, and so you only have 2 or 3 in your hand, but really you need 5. How do you help them get to that space where they can manage their symptoms better, and may need some support in doing so? And then ultimately giving some holistic recovery services. Think beyond just therapy, right? It could be spirituality care, it could be art therapy, it could be yoga, it could be all of these other things that ultimately help us get to a space of recovery. And each person's journey is different and special and unique in its own way. As a provider, you have an incredible opportunity to help them navigate life and live it to the fullest. And as a client, you have a unique opportunity to have a hands in full decision making of how you navigate all of these things, which I think is so beautiful and precious. All right, I know I have talked at you for 44 minutes. Tell me what questions you have, what things I can answer, comments you may have. You can put those in the chat and we will answer those.
Sadie, you are wonderful at presenting.
Thank you.
You're welcome. Yeah, please put your questions in the Q&A and I can kind of moderate and read them. Oh, there was one question about, would you be willing to share the PowerPoint?
Yeah,
Okay,
absolutely.
awesome.
I'll send that to you once we wrap up.
Thank you. She was thorough. She was thorough.
That's the goal, right? Knowledge is power. I just want to share all of the knowledge that lives with me so we can support our communities.
Someone said this doesn't have to do with the webinar, but go Bulldogs.
Yes, go dogs. Listen, it's a new season. I cannot wait for August. I'm nervous for where the SEC is. Go dogs.
Love that. We can give it a minute in case people are typing.
Yeah. Yeah, no need to rush any humans.
Well, I just really want to say thank you. I
Yes,
appreciate
thank
all
you
your
so
work.
much for having me. Absolutely. I know sometimes questions come in or you have some other thoughts after the fact. Danielle, I think if people reach out, I'm happy to answer those questions too. Door always open. You have my contact info. So
Okay, perfect. Great presentation, very informative. Thank you. And then it says, do you know if there's any services for smaller towns such as Watseka, etc., which is like an hour north of Champaign?
yeah, good question. I am from the Rockford region. I know that Rosecrance provides services. We have a Danville location and a Champaign location. Like I said, I don't know all of the directions, but Rosecrance has that. I also want to note that we have virtual services. And so if you have individuals you would want to refer individuals who would be a good fit for that, virtual is also an option. They have day, evening, but virtual is there too. I know there's nothing like going in person, but it's an opportunity as well.
Thank you. I don't see any more at the moment, but I would definitely pass them along to you if I get
Yes,
some more.
absolutely.
And thank you again, and thank you everybody for joining us. And I hope you
Yes.
have a wonderful day.
Thanks, guys. Have a good one.